Hello, everybody. This is Jessica Hoy from Winona State University, joined by Jake. And I will be doing some voiceover recording on chronic obstructive pulmonary disorder, otherwise known as COPD. So I'm going to share my screen and we will begin with chapter 1. This will be 2 chapters long, by the way. So So COPD, otherwise known as chronic obstructive pulmonary disorder, basically mismatches the ventilation, the gas exchange, with the perfusion of needs of the body. So we'll see symptoms in our clients like shortness of breath, wheezing, chest tightness, fatigue, difficulty with routine activities, weight loss, and muscle loss. COPD is really 2 diseases acting at the same time on the respiratory system. It's emphysema and chronic bronchitis. COPD patients may have one disease process that's more prominent than the other, but both emphysema and chronic bronchitis are present for the patient to receive this medical diagnosis. Now, spoiler alert, I did this presentation as concept maps. So here we go. Concept map number 1. Oh, sorry, I got ahead of myself. This particular video clip is amazing YouTube about understanding COPD, and I highly recommend that you take a little bit of time and watch it. Now, concept maps. So, first, we're going to talk about the 2 different components of COPD. I'll take a break and then we'll talk about nursing management. So component number 1, emphysema. As we heard in the video, emphysema is primarily caused by smoking. Environmental pollutants can play a part. There's about 1% of the cases in the United States which are caused by a genetic defect. But emphysema develops because in the irritant, basically smoke, causes inflammatory responses in those alveolar sacs, those bunchy, spongy ends at the end of our little bronchial tubules. The alveolar walls are broken down by protease enzymes. The result is breaking. I'm sorry, Jake just decided to start pawing on me. You're fine. So the alveolar walls are broken down by protease enzymes, and the result creates byproducts, which are also seen by the body as irritants. And then the body continues to make more enzymes, which releases more alveolar wall breakdown. And basically the breakdown just continues as this really big cycle. Damaged alveolar walls, they lose elasticity, and they lose elasticity, and Jake, come on, man. Okay. And they're not able to exchange oxygen and carbon dioxide. So the damaged walls aren't able to move gases towards the bronchial tubules. The gas stays in the sac, and that causes hyperinflation and dyspnea. Hyperinflation here. And then the lack of gas exchange in the capillaries changes the blood gases. So then that actually increases serum CO2 levels, decreases serum O2 levels. That stimulates the brain to increase the respiration rate. It activates the use of accessory muscles, all in order to compensate for the lack of oxygen that's available in the blood. So as you can see here, we have the dyspnea, we have the accessory muscles used, we have a decrease in elasticity. The abnormal blood gases increase the respiration rate. The dyspnea increases the respiration rate. The hyperinflation is from a decrease in elasticity. And then what will happen is this hyperinflation is what causes that barrel chest that we see a lot of our COPD patients having. And then the hyperinflation also causes those airways to collapse, as you can see. So chronic bronchitis as a disease process is primarily caused by smoking, but it can also happen due to a greater number of recurrent bronchial infections. So similar to emphysema, the irritants cause an inflammatory response, but this time it's in the bronchial tubules, not in the alveolar sacs. So the emphysema is in the alveoli, and the chronic bronchitis is in the bronchial tubules. The irritants also cause a cellular change, and makes more goblet cells because the body's just like, I'm being constantly bombarded here. I need some more protection. Goblet cells do that by making mucus. So then there's an increased number of goblet cells, and then we end up with a hypersecretion of mucus in the large airways to help protect the airway from the irritants as well. The chronic inflammation, the increased mucus also causes smooth muscle hypertrophy, getting that mucus out really hard. So that hypertrophy, they're like just maxed all the way and they can't get a good squeeze because there's just too much there. Means that they can't get the mucus out. So physiologically, the patient develops a prolonged expiration and they develop labored breathing. The prolonged expiration leads to decreased oxygen availability, and it also leads to carbon dioxide retention. These two factors and the gas availability changes result in cyanosis and increased RBC production. And that increased RBC production actually leads to pulmonary hypertension. There's just so much blood that's going on in here in the body because it's oxygen starved. And then it can also cause right-sided heart failure. And what will happen is that right-sided heart failure, there's just so much blood to move through the lungs and it's so hard to move it. The right side of that heart, that right ventricle is what's in charge of moving things through the lungs, starts to fail. Because of the right-sided heart failure, we'll also see peripheral edema in these clients. And the peripheral edema, you'll be seeing the swelling of the legs and any sort of dependent limbs. And then you can also see what's called cor pulmonale, which is also known as right ventricular hypertrophy, where that right ventricle is actually too big to actually have a good muscle contraction as well. Labored breathing, just so that you're aware, will actually result in weight loss, both from the increased work of breathing, right? It just, you can't breathe and not use your muscles. So just that increasing using of your respiratory muscles will cause an increased metabolic rate. But the patient may also lose their appetite because the body is just so focused on breathing. Your body wants to breathe more than it wants to eat. So COPD patients will pick breathing over eating, and then they'll have weight loss from that as well. So not only is the body working harder, but there's only so much energy to go around. Breathing takes more energy. Breathing is more important. So they will end up having weight loss because they're just not being able to meet their nutritional demands. So I'm going to stop sharing here. This is the end of chapter 1. COPD chapter 2 is coming up. So follow the next link for COPD chapter 2.